Welcome, everybody. Appreciate everybody attending this event. My name is Brandon Herman. I lead the employer partner organization for Guild Education. Guild is a education, skilling, and mobility. Is this microphone? Is this like a... Did everybody hear me okay? Okay. Guild is an education, skilling, and mobility provider. So we work with large organizations across financial services, retail, and healthcare. So we partner with organizations like Walmart, Hilton, JPMC, and a number of the largest health systems in the country to help them attract, retain, and upskill talent by providing the skills and education that their workforce needs. And I'm really looking forward to the conversation today with Dr. Laura Daniels and Katie Giles. I'll let them both introduce themselves before we kick off.
Thanks so much, Brandon, and hi again for anyone who saw this morning's panel. My name is Dr. Laura Daniels. I am with Wellstar Health System. I'm their Chief Talent Officer, where I lead our people and culture strategy as well as talent management. And then also I'm an adjunct professor at Columbia University talking about human capital and workforce challenges.
Hi, everyone. So I'm actually, I do have my doctorate. I don't ever use it, though. I'm Dr. Katie Giles. It's like a moment we're sharing here. So I work at, this one's going to be a long one, I am Kindred at Home's hospice division, soon to be known as Gentiva Health Systems, if you are paying attention to the transactions of the world. And in that organization, we're standing up and lifting a company that's been spun. So when you do that, you have to build all the bricks again, or you sure have to look under every single brick that built that company to make sure you still want that particular brick. So in my current job, I lead learning, development, clinical competency, skilling, talent initiatives, recruiting, all the fun things that involve having the right people in the right job at the right time.
Awesome, thank you both. We've all heard a lot today about the talent challenges that exist in the healthcare industry, and I know most of you are sort of living through that right now, but I just wanted to start with a question. Can you both talk a little bit about your biggest priorities and the hardest challenges that you're working to solve right now?
Yeah, absolutely. I think specifically when it comes to workforce development and just talent overall, of course, I think there's no one in the room from healthcare organizations, whether you're on the payer or provider or any sort of side, where retention is not something that you're really aware of right now and struggling with. So I think first and foremost, that is a huge priority of ours to tackle that turnover. Secondly, I'd say, the strategic workforce development piece we've been talking about today. Earlier today, I had referenced this as kind of your mix between your buy and build strategy. And so really knowing that we're going to have to build talent within the workforce much more than we're able to buy talent is a big piece of that. And then I think the third piece is really around our talent attraction. It's increasingly difficult, especially when we look at competitive markets, especially I think here in the Southeast in Atlanta, we have a very competitive healthcare market. How do you differentiate yourself as an employer?
And I think a lot of us share the same problems. We have all that, yes. And then specific nuance of not everyone wants to work in hospice. I know that's shocking. But hospice can be a particularly difficult part of the healthcare ecosystem to recruit into. You can't like pay people into doing that particular job. They have to want to. So retention for us is incredibly important. Interestingly, the attraction part's not the hardest part. It's the keeping, because I think a lot of people believe they want to work in hospice until they realize how very draining it can be to work in that environment, coming off of the behavioral health one, and probably some real crossovers there. So for us, if you find that person with what we call the hospice heart, you love them and you hold them and you squeeze them forever because you really don't want them to leave. They're very hard to replace, people who really feel it in their soul. And then the other one that I would say is like a big need and a big priority in our area is our leadership. If you stay in our organization long enough, you're going to become a leader, whether or not you're ready to become a leader. I think that's true for a lot of our environments where, congratulations, you're still here. Now you shall manage. They don't teach enough of leadership skills in the way clinicians are raised, right? It's an individual contributor job inherently, And then we're like, now lead all these people with all their peopleness. It's hard. So preparing our leaders and our leadership and stemming the flow of their attrition, but also really giving them the skills that they need. There's a lot of mentions of servant leadership. We personally follow or working through following a trauma-informed leadership model, which is the same, but really focused on recognizing that when our nurses come off their patients dying, which is every day, there's the feels, all the feels, and we have to make space for that.
Awesome. Y'all both talked about the importance of retention. Obviously, you can do the best job in the world of attracting talent, but if the bucket is too leaky, then it is hard to staff the way that you need. When you think about the way that the employee value proposition needs to evolve within healthcare and within your organizations in particular, what are the big focus areas from sort of an EVP evolution perspective?
Yeah, great question. I think it's interesting, kind of looking at what's happening across industries and what you're hearing from like the big research studies where they're talking about, career mobility and, the ability for career growth and learning and development are kind of that number one ranking across the board and have been for, 5 to 10 years straight. What we see in our exit surveys, sometimes is a little bit different. So we may see that, to Katie's point, manager quality, leader quality impacting things, compensation's always up there, as I think it will continue to be. And so I think wellness and burnout obviously are a huge piece. We've got to tackle all three of those and this career mobility piece. I think sometimes when I look at the data, it doesn't always tell the full story, but when you really dive into it, it's not just pay in my current role, it's did I have an opportunity to advance my career and earn, better wages overall. And so I think as we are looking back and stepping back, we've done really great in certain areas. Like when you look at what we've done around wellness, our head of total rewards, Danny Abad, I would give him a shout out because we've really made huge leaps forward in the wellness space from wellness rooms at our hospital sites where people can have, VR relaxation or a massage chair and, have time to decompress, to support around mental health through, things like Spring Health. So I think we've really done well in that wellness space. I think the manager quality and is a huge component. And there's a few challenges we're facing. So we've definitely had a huge expansion of just the amount and types of leadership development that we're offering, from like more, personal reflection and opportunity from like assessments and things of that nature, to real team building with care teams, to where they understand how they're working together. And then also, beyond your formal leadership development programs, how do you take also more of a digital lens? A lot of our workforce personally is also remote, and so, or hybrid, for example, that are not actual clinicians. And so creating digital kind of leadership experiences is also an important part of that. And I just add to that, on the manager quality side, I think it'll be really important. There's just too many things to do, right? And our poor leaders, you will probably all hear it every time, the folks up in a corporate office come out with a new initiative. It's, oh, and your leaders will play this role, and here's a new initiative, here's your leader to do of the week. And they're sitting here saying, how do I make sense of these 25 different initiatives? And so I think organizations really need to step back as well and be really thoughtful about kind of the end impacts of all those different changes they're rolling out to leaders so that leaders have a more manageable job. And so that's another piece of work we're focused on. So lots of work. I could talk endlessly about our employee value proposition and the different areas we're focused. I think those are two big ones. The other one I'd point out is just diversity, equity, and inclusion is a real area where we're trying to make steps forward and need to make a lot more movement forward.
So in the process of standing up an organization, you have to take a pause and think, who do we want to be when we grow up? I don't have an EVP. We don't have one yet. I'm still working on that. What I can say and share is, I think a critical step that we miss as leaders who know really smart people in rooms who know a lot of things with a lot of experience. We're all one of them, right? We've all been in that spot where you think, you just know, your gut knows. But then you read things like the ANA has been saying for how many years that nurses want development more than anything else. And every year we say, but we'll increase your wages. And then we're confused why the wage mobility didn't necessarily stick. Because what we didn't do, we didn't listen to what the nurses were saying. And for my organization, I came from another healthcare institution. What the ANA has said year over year has borne out as truth when we do the internal findings within our own workforce. The clinicians know what they want, and being willing to put ego, preconceived ideas, maybe they don't want branded swag. That's a thing. We're in 38 states.
No more T-shirts, please.
No more mugs. We should send them a mug. They don't want mugs. You know what they want? A lower caseload. That is what they want. And if you take the money that you just spent on those mugs to rethink some things, right? A company that shall not be named that I consulted on spent $3 million a year on swag that people give to their kids or whatever, right? Think of what you could have done with that money. So really listening and being willing to do what the people told you they want. And this is where potentially I get a little bit polarizing. It's in my personality. Your executives don't know what your frontline people want. They don't. And executive development is an albatross of a cost that talent development carries. And if you think about tens of thousands and bazillions of dollars that's going to people who can actually afford to do that for themselves and get their own education to stay relevant. We have there's a million resources at our fingertips. We need to be willing to put that level of investment in the people who are at the front lines of our organization, because that exceptional experience for that employee will time and time and time again build an exceptional patient experience. We say the words as organizations, but our words and our actions don't always match. And I think marrying those things together, whatever Gentiva Health Systems EVP will be, when that mystery is unveiled, the words and the actions and how we measure that those things are very close is going to be key and critical to us.
I was just going to say, I wanted to add on one point you said, which is that if you look at the overall spend from a development dollars by level in your organization, historically you used to see, 30 to 50% of that spend at executive levels. And I think when you're seeing organizations who are doing better in the retention of their team members, that spend has dramatically shifted to the front lines, especially at frontline leadership in areas like that. So I'm hopeful to see more organizations really take a look at that holistically. The speaker that was just in here was talking about, you can tell what companies care about by just looking at their balance sheet or what they spend money on. And so that's a really important metric for anybody who is working in talent, is to know at what levels you're spending the dollars.
That resonates deeply. Let's dig into that a little bit. So you mentioned that there's sort of lots of studies about the Great Resignation and why people are leaving. There's one I saw recently from McKinsey, and they sort of talked about the three biggest reasons being people want jobs with purpose, they want pay for today, and they want pathways for tomorrow. Healthcare kind of has in some ways this inherent advantage in that jobs with purpose is already baked in, right? Most organizations have responded on pay. We've seen pay go up in general more in the last 2 years than we have at any time in the last 40, and that's not to say there isn't still work to be done there, but there has been a response. I think the place where people have responded more slowly is on pathways. And you've both talked about learning development, you've talked about the need to emphasize frontline workers. One of the things we think a lot about is how do you take people from entry-level jobs to gateway jobs to destination jobs? People don't want jobs, they want careers, people want opportunity. So how are you thinking as talent leaders and L&D leaders thinking about how do you do that, and what are the pathways that you're focused on in your organizations today?
Yeah, this is a huge effort for us, as you pointed out, and I think, historically, healthcare wasn't always thinking, that we had academic partners, but I don't know that we thought about the relationship and how critical they were to our ability to have a workforce. And so to your point, I think we started probably where the pain was the greatest, which was around our both our clinical roles, but also our clinical support roles and those career pathways. And so we've invested a lot of money into areas like certified nursing assistants, CMAs, we're looking at RTs and surge techs, for example, are areas where we're starting to look. The CNA and CMA programs have seen huge success. What I'd say is the other huge benefit, you can kind of tackle two things. One, if you're struggling in the market to be able to hire a CNA, for example, and you can build a program where you're actually going to create your own, you also are going to get significantly higher retention from that. And so we're seeing almost double the retention from the folks that are going through our own CNA programs from folks that are going through other programs. So that's a huge piece for us. The other piece that's not talked about a lot that we have a desire to get much more into is really around these entry-level roles. And I think as an organization, our mission is to enhance the health and well-being of every person that we serve. And we as a not-for-profit health system have a commitment also to the communities that we serve. And so I think thinking about and understanding how we're helping people at, entry-level, roles increase their wages to get to the middle class is something that we as an organization care very much about. And that's an area of work that we're just starting to get into that we'd like to do a lot more.
This is the particular passion point for me. So hospice, you can probably imagine who works in a hospice branch. It's not a hospital system that's filled with thousands of diverse roles. There's like 7 clinical jobs. It's pretty clean. But there's bazillions of all of them, right? Like we don't need one aide. We need aides everywhere in the United States. And finding a CNA is rather difficult in this day and age, but we can find them depending on what the market is, whatever that local market might be. And if you get an aide in who's willing to voluntarily work in hospice for that wage, that's a person, that's the hospice heart, is what we call it. They've got the hospice heart. They've decided to work in this field doing that job for that wage. And you have to assume that the personal calling is there. So when we think about internal mobility, do I care about the accountants and the salespeople and the other parts of the hospice organization? Sure, I absolutely care. What I really care about though, like to my toes, is if a CNA becomes an LPN, we just doubled her wages. And if that LPN moves to an RN, we just doubled her wages again, right? Depending on the market they live in and all that kind of market pressure stuff. But imagine the halo effect of that. So we talk about our pipeline problems. If you come and work for my company, my friends up here, you come work for my company, and you start as a CNA, and I double your wage, I pay for your education, I get rid of the ridiculous tuition reimbursement model that is a non-starter barrier for people who make even big wages, right? That first check you have to write is insurmountable for some. You get rid of the tuition model, you pay for someone to go back to college, you help enable them to get a job that doubles their wages. The halo effect of that, now their mom's working for us, their aunt's working for us, their 3 best friends are working for us, they're yelling from the rooftops. And hospice is, the utilization, there was actually some speaking about DE&I, there was a fairly depressing set of research that was put out where, I'm going to mess up the statistic, but it's something in the high 80% of hospice beneficiaries are white, they're Caucasian. There's whole marketplaces that are not capitalizing for so many reasons on the hospice benefit. If you can use your workforce as a way and make an incredibly diverse workforce and provide opportunities and remove barriers, again, it parlays itself into your impact to your patient population. So it tends to be that 1 to 3, 1 to 5 match. You get your money back a bazillion time folds over because you're being really intentional about where do you need your services to go and who are the right people and partner. And chances are it's that CNA who's supporting a family, sitting in, I'm in Louisville, Kentucky, sitting in Louisville, Kentucky, right? And now she's gonna tell all of her friends and come work for our company.
Begs the question, what are the obstacles? Like, why isn't the way you two explain it, it seems so obvious. Why aren't organizations more focused on the front line? Why aren't they more focused on mobility? Why aren't they getting rid of tuition reimbursement when there's so many ways to provide tuition assistance? Like, what do you think is stopping this progress?
I think it's a big, heavy idea. You have to be willing, in my current company is smaller, my last company, I had to be willing to go and ask the CFO for $25 million. Was that fun for me? No. No. Was it me putting my words and my actions together? Yeah. You have to be willing to fight for it and find the right friends. In that job, I worked in human resources. The CNO became attached to the hip. That chief nursing officer had no idea what hit her when I walked into her office, but by golly, I got a sponsor at the end of that rainbow. The CFO got him. You find your digital health and analytics person, whoever they are in your organizations. It's a big, scary thing with a big, scary price tag, but the cost of investing in somebody is less money, less work than the cost of replacing them. So to me, it's the math works. But for those of us who are in learning and in talent, and the whatever poor manager who makes what, like 60,000, like some middle manager is responsible for tuition reimbursement policy. That person probably does not feel empowered to say, I need to change this because it's a systemic part of the problem. Because there's a disconnect between where the cost of the problem is and what it's creating, and where the ownership of it, I think, in a lot of organizations.
Yeah, and to build off that, I love some of the points you made. I think in many organizations, tuition reimbursement has been looked at, in many shops, this falls into like the rest of benefits in that realm. And so it's looked at as one more thing. We offer these, you can get these commuter passes, you can get these state park passes. We've got tuition reimbursement. It's in this kind of overall offering of tuition reimbursement and not necessarily always connected to strategic workforce development. And so I think, while organizations are putting this out there, are they really intentionally pushing certain career paths that are their, 10 hardest to fill or their, top 10 turnover roles? Those connections haven't been completely made. And I think to Katie's other point, it all comes down to a business case. And so when you're talking about things like turnover or talent attraction, you're talking about a lot of invisible costs. And I think, human capital, HR, have really struggled as a function to be able to communicate return on investment or, HCROI for many years. And so I think, people that are working in human capital or HR being able to really communicate, this is the dollar investment, this is the return, and here's the cost of that turnover, the time spent recruiting, the cost to onboard a nurse, which is north of $50,000, $60,000. And so if those costs people aren't aware of, yeah, it seems like a big investment. But if you're able to put together a business case that shows that, it's really not a huge investment to say, this is a no-brainer, we're gonna do it. Oh, and by the way, most organizations probably don't understand the equity issues that a traditional tuition reimbursement model creates, because by the way, my EVS worker, the front, entry-level worker, can't afford, to Katie's point, to pull out $3,000 for a course, hoping that they get a certain grade at a certain point that they're going to get reimbursed. So then you just have this benefit that's going to all these people getting secondary degrees that's not really helping with, I think, what they intended it to do.
I love the kind of connecting the dots on the business case behind this, because it seems it's clearly the right thing to do. And now how do you build the business case behind it? Y'all talked a little bit about clinical support staff. I don't know if you've seen this data, but I've seen it, which is one of the reasons for nurse attrition is when there's a lack of clinical support staff, it leads to nurse burnout, right? So I think it's just about like connecting the dots and creating the logic chain that says, hey, I know what Miss C or Mr. CFO care about is the nursing problem, and it might not be the clinical support problem, but by fixing that clinical support problem, you're actually also impacting the nursing problem.
100%. I mean, think about in COVID, how stretched anyone in a provider capacity was, and trying to think through what else, what if we had a care partner and then we just had like an additional worker who was doing any random thing that came up that wasn't clinical in nature, but anything to support that. And so I think, some of the most undervalued folks within healthcare are those people on the front lines. I mean, you think of somebody who put their life on the line as an EVS worker in COVID, why did they choose to stay an EVS worker in a hospital in the midst of a pandemic when they can go to a Walmart or a Target? And so I think, we also have to, really think about those entry-level workers and what's the value proposition other industries and companies are giving them. Because if, Target or Walmart or these companies are now saying, we're gonna pay for all your education, it's a really hard sell to say, help us, reduce hospital-acquired infections and help us clean patient rooms. And by the way, we can't do all that for you, and we don't have all the perks. So I think companies across the board are rising tide raises all ships. So if, certain companies have made these investments, it's going to force, the employers as a whole to really rise.
And I think in the last panel, she brought up a great point that healthcare is behind. Like, the other industries get it, and a lot of them have made the full switch. If I need more data workers. Does anyone, like, you have that in your, we need more data workers. The sky is falling in because we need more data workers. If you need a data worker, there are pathways to get this accomplished through public, private, government, academic institutions that have come together to build these systems of stackable credentials that cost no money out of pocket for these future data workers. We can learn from these other industries that have already figured it out. We have to collaborate together to make it happen. Somebody in here who I don't know yet, we don't know that we're friends yet, but someone in here is gonna help me stand up a hospice specialty. I don't know who it is, but we're gonna do it together, someone. And it's gonna be amazing because there's no point in my organization or any home health organization carrying the load of education by ourselves when there's wildly capable education partners who are equally committed to bringing more healthcare workers into the ecosystem. And so they figured it out in data, they figured it out in finance, they figured it out in service and retail. It's our day. Like, healthcare's, we gotta step up.
Yeah, couldn't agree more.
You've both talked about DEI initiatives. I'm curious how you partner with your chief diversity officers, either now Katie or previously back at Humana, and how you kind of think about L&D and talent through the lens of DEI.
So it's amazing respects. You said my employer, it's fine. It's totally fine. But, you know, I try not to wear the health insurance thing around my chest. Like, it's fine. Came from Humana. It was a lovely place to work. 15 years there. Amazing DE&I focus, wins all the awards. Huge advocate for bringing the switching from tuition reimbursement to deferred direct payment. Theirs is released and in the ecosystem now that they have done that. So I'm not spilling any former employees' secrets here. But one of the things that I learned in that organization, that in my current organization, I'm doing things differently, is I have my DE&I leaders reporting to my talent leaders. And so the person who leads performance reviews, education benefits, like, that person's equally responsible for driving DE&I initiatives, because I needed our DEI and B team to have, like, power and teeth and funding, and separating in DE&I Island immediately diminishes the work. And so is my way gonna work? I have no idea. The company's like, I've worked there for like 9 months. Company's not even fully legal and standalone until October. But we're gonna try it and see what happens when we say, it's not a clinician and a professional. It's not a diverse associate versus not. It's just a human being. And that human being, by compiling all the things that need to fight and advocate for their experience in our organization, I want that in one centralized area. Because my belief is that it's all interwoven, and my hope is that by doing right by selection processes, changing the policies of tuition, doing things like that, I'm ultimately driving a more efficient and less performative DE&I function. We'll see if it works, but, you know, if I end up in the news, well, no, it wasn't great.
Agree with many of the things you said. I think to your question, you know, DE&I, you know, as a standalone function, you know, there's many reasons to have DE&I as a standalone function, and DE&I must be woven into every single part of the employee experience and every single talent function. And so, you know, partnering with our Chief Diversity Officer, LaJoyce Naylor, you know, she wants to know and understand, and we want to know and understand, what do performance reviews look like? What does, you know, our succession process look like? How are we identifying and promoting diverse talent within the organization? You know, one of the first activities that we did a couple years ago when I came on board was wanted to understand what's really happening. A lot of times people, you know, DE&I can kind of be like episodic. You'll see like, oh, we're gonna do these events or we're gonna have affinity groups, but it really needs to be systematically woven into what you're doing. And so understanding our data both in how we hire, comparing and understanding. What does it look like for blacks versus whites, for women versus men, how we hire, then looking at the pipeline of growth and actual promotion and growth by role in the organization, and then in your exit interviews to understand what those look like. And so I think the data piece here is critical, not only to understand those talent flows and what's actually happening so you can target your approach, Because you may think you have a problem in one area, but really you have a completely different problem. And I'd say the same thing needs to be done for things like employee engagement data, exit survey data, to understand the different experiences folks are having. And I think organizations that are doing a really great job in this, they are recognizing that the moments that matter in the employee experience journey are really different for different employees. So I'm, in my mid-30s. I care a whole lot more about career advancement than I do some of these benefits. I don't have a family, so I'm less concerned about that. And so understanding that you're going to need to personalize that employee experience to individuals and understand what is important to them, I think is a critical piece here too.
I think sort of the integration between workforce development and DEI is such a powerful one. Most large organizations are actually quite diverse. It's just that diversity wanes as you move throughout the organization. So if you really want to drive equity, the ability to lean in to providing the education and skills and development to move people down those pathways, and really to focus on frontline populations, not necessarily high skill populations, is such like a seemingly obvious and powerful lever that companies can start to pull. So I love that you're both thinking about it that way. I'm curious, sorry, go ahead.
I'll say one of the things, so I think Laura and I both dance in this like somewhat in HR talent land and somewhat in healthcare land. They're two very separate. In HR talent land, I'm not the only one with purple hair in any given room. In this, well, not a lot of purple. Where's all these purple hair, guys? It's a different, what you care about, what we talk about, it's very different. And one of the things that I see a lot in HR talent land is this constant talking about benchmarking your employee experience, your candidate experience. What experience are you driving for your people? In healthcare land, we only talk about how are we benchmarking and measuring our patient experience. There's a miss there where putting with the data, it's being willing to be vulnerable as an employer and put yourself up against other employers, not necessarily in your same industry. Because when I look at those 100, I was looking at one yesterday that was the 100 best companies for candidate experience and the 100 best companies to work by like Forbes, I think that one was, in the talent board. And I think like between the two lists, there were like 7 healthcare companies. Is it ego? Is it systemic, like we don't need to know this stuff? Is it a systemic problem? Why don't we look? Healthcare, we don't look. I've only done the candidate experience one. I've never done the best place to work one. We're gonna give it a whirl and see what happens. I work in home health, I don't have my hopes, but at least then I'll know where I stand benchmarked against best places to work.
Mm-hmm.
I think we hear a lot about socioeconomic determinants of health. And I'm curious if either of y'all or your organizations, how you think about sort of what your responsibility is to the communities that you serve and how you view that through the lens of workforce development, right? We've talked about pathways and mobility, and when you kind of view that through the lens of socioeconomic determinants of health, it starts to bring kind of a whole nother angle to it. Is that something that internally your organizations think and talk about?
Yeah, absolutely. I mean, there's no question DE&I is very different in healthcare than other spaces because at the end of the day, the socioeconomic or social determinants of health have a huge impact on actual patient outcomes. And so for us as an organization, where our team members are coming from the communities of the patients and communities that we serve. And not only that, but if we're able to help people in local communities, take West Georgia, for example, a more rural area, to be able to people to move to better incomes and better wages, it's going to help them overall in terms of health outcomes. So I think there's absolutely an important part there, and I think that's an area as well that foundations and philanthropists are also, and there's grants available, I think, that can also really help in this area.
This one we're not as robust on thinking in sort of the broader community. I think there's a lot of work and effort that goes into why are Caucasians immensely the dominating force in consuming hospice services. Hospice is a wonderful thing. Anyone who's been through it with a loved one comes out the other end generally very much feeling like they were cared for. It's a really compassionate and empathetic way to handle one of the hardest stages in a family or in a loved one's life. And so when we talk about our responsibility to our community, some of it is where are we not permeate, this like sounds weird, right? But where are we not permeate like a market share It's a goofy way to phrase it. It's probably, and it's also not how it really gets phrased, it's how I think about it. Where if we know it's good, and we also know it's fully funded, and people don't come out of pocket for it, why isn't it being consumed and utilized in many parts of our company and communities? So there's a little bit of that. There's a lot of thought put into, do our employees have the tools and resources that they need to show up every day at the best they possibly can? So for us, it shows up in ways like, if we know we're gonna have a lot of growth in New Mexico, for example, we may struggle to recruit or find healthcare workers that are bilingual or even have enough command of English language to be able to work through our coding, systems and whatnot. So with the tuition reimbursement, ESL is put in there. It's critically important to make sure that we have ESL as part of our benefit, that no employee is going to come out of pocket if they need to utilize that. Computer skills, technical literacy, digital literacy. Like if there's human beings entering our company and they're missing a skill because some critical component of their journey just hasn't been met yet, we need to be there to meet that for them. So tuition reimbursement, we tend to talk and think about it in the form of how are we applying it for credit higher ed academic institutions. The reality is it's good for GEDs, ESLs, certificates and credentials, all those things that community college, all those things that oftentimes get people, if you offer to pay for what they need, whatever might be causing a barrier for them to be professionally successful. I've never had anyone turn me down. No one's ever said, no, I don't want ESL, or no, I don't want it if it's offered to them. They take it, and then there's success after the fact. So our community, it tends to be really centered on the human beings that we work and the halo effect that grants for their families.
Awesome. Thank you all so much. I think we're supposed to wrap this up here. I think it's easy to look at the challenges facing healthcare and feel like they are extremely daunting, to look at kind of the talent and labor crisis and feel like, oh my gosh, there's so many structural issues that are so hard to fix. And that's in some cases true, but it's also, I think, reassuring to think about the low-hanging fruit, some of the obvious things about, gosh, if we just do the things that are going to help us retain talent and slow the leaky bucket and keep talent within this industry from pivoting into other industries and focus on upskilling and reskilling and really committing to the people that have committed to public health, there's some low-hanging fruit there and some high-impact low-hanging fruit. So I walk away from this super encouraged and appreciate y'all's time. Thank you.
Thanks for having us.
Thanks, everyone.